Welcome everyone. So my name is Robin Doeswijk. I'm head of EHA's European Affairs Department. It is my big pleasure to co-host this event. I hope to have a chance later today to say a few words about why EHA is so active on HTA, why this is so important to us. But we're on a pretty tight agenda. So I'm not going to take too much of time of our introductory speaker, who is Francis Arickx, the head of the Pharmaceuticals Assessment and Reimbursement Department at RIZIV INAMI, the institution that has kindly agreed to host us here today. Francis, I will let you take the microphone. We have been informed that the next speaker, MEP Sokol, will be joining at 4 p.m. sharp, so we need to try to stay on schedule. Francis, the floor is yours, please.
Thank you very much. It is my honor and my pleasure to welcome you and the European Access Academy in this Galilei building, which has been the home of the National Institute for Health and Disability Insurance for a little bit more than 5 years. You will have to trust me on this. The view on Brussels from the 12th floor, where we are, actually, and which is off limits for you, is amazing. But you are going to be stuck today, I'm afraid, a little bit in the dungeons of our building. It's not really accurate either, strictly speaking, because we share this site with the people from the agency, with the public federal service for public health. In most countries that is called the ministry, and probably very soon also with people from Cienzano and the Belgian Knowledge Center for clinical excellence, as a part of an intensified collaboration across our areas of expertise. The National Institute for Health and Disability Insurance, the RIZIV INAMI in Dutch and in French, is a federal public institute, was founded in 1963 as a crucial part of the social security system that exists in Belgium. And we're responsible, or RIZIV is responsible for organizing and overseeing the Belgium's compulsory health and disability insurance. That means that it manages, RIZIV manages healthcare insurance and allowances and benefits related to, for instance, incapacity of work. We operate under the supervision of our Minister of Social Affairs and Health, that's Minister van den Broeke, and we work closely together with a wide range of partners, including healthcare providers, sickness funds, but also the social partners, but also in case of reimbursement of medical devices and pharmaceutical and medicines with the pharmaceutical industry. RIZIV INAMI's core task includes helping to set the policy direction for healthcare and managing key aspects of the social security, obviously. And we therefore play an essential role in safeguarding, or RIZIV plays an essential role in safeguarding access to healthcare and supporting healthcare providers, the doctors in Belgium, including through the reimbursement of medicines. That also means that actually RIZIV INAMI is not an HTA agency or not an HTA agency pur sang. We, with the Commission of Reimbursement of Medicines, practice something what I would call applied health technology assessment. That's health technology assessment that directly supports the decision-making process on the reimbursement of medicines and of medical devices. For me, actually, health technology assessment has never been merely or a pure academic exercise. It always serves a purpose. It must equip payers, or if you prefer, and I do prefer buyers, with the essential evidence and insights that are needed to allocate often limited budgets. And these budgets are getting limited, more and more limited year after year. To allocate these budgets wisely and to make sometimes very difficult or complicated choices when needed or required. must, on the other hand, help the policymakers to understand the value of investing in our evolving therapeutic arsenal, so they can shape health policy that is both forward-looking and resilient. I don't like the word resilient. I prefer, because it's used too much lately, I prefer future-proof. But what our policy needs to be is looking at the future and making sure that it is future-proofed. And thirdly, and probably not lastly, but thirdly for me, HTA can support patients and healthcare professionals, especially when they are addressing or looking for solutions for unmet medical needs, by helping them to gain insight in the true value of the new medicines that are presented, and that is sometimes something that is really complicated, making the distinction between uncertainties and expectations. Because decision makers tend, and we see that also in the professional environment of a Commission of Reimbursement of Drugs, even professional decision makers tend to mix them up sometimes, those expectations with uncertainties. Over the next 2 days, the European Access Academy Spring Convention is going to focus exactly on that HTA, and more specifically, we will take a deep dive into the European Joint Clinical Assessments, which are now roughly, a little bit more than that, but roughly 1 year into full implementation. I know they started officially on the 13th of January from last year, but first files only came in a little bit later. In fact, it's not going to be a deep dive. It's probably going to be, or hopefully going to be, a deep dive on one hand, and a high climb on the other hand, to look to the future. So a mix of looking back and looking forward. For the past few months, that future, actually the whole world in which we live and we work, has gotten a thorough makeover. I think you know what I'm talking about. We may not yet fully understand how, but it is increasingly clear that overseas policies and politics, call it geopolitics if you want, will play a decisive role in shaping the access to medicines, and certainly the access to medicines in Europe, if it is not already happening. RIZIV INAMI and our minister, you might have heard something about that in a speech a few weeks ago in Paris. We are convinced that cooperation is key in shaping our response to these recent developments. I'm not going to start all over. RIZIV has always looked, RIZIV INAMI has always looked beyond its own walls, and collaboration or cooperation and facilitating collaboration is actually in the genes of RIZIV INAMI. In our national contexts of the health insurance, that means collaborating with and that happens in the Commission of Reimbursement of Drugs, but it happens everywhere actually. It means collaboration and consultation of all our stakeholders, healthcare providers, patients, insurers, industry, and others. Internationally, it means that we are working intensely together with our colleagues from the Benelux collaboration, with the colleagues from the International Horizon Scan Initiative, with EURIPID, with PPRI, with the network of competent authorities for pricing and reimbursement, trying to shape and prepare for the future at the same time. In the same spirit, or in that same spirit, RIZIV INAMI has committed to leading the framework contract consortium, and has committed to invest in the Brussels Center for Collaboration in Health, and I'm happy that quite a number of people from BCH are here in the room, which supports that consortium, supports the consortium members, supports the experts, the patient experts, and the HTA coordination group. Because we believe that collaboration is the way to go. I'm largely in time, so allow me to welcome you again on the one hand, and on the other hand, wish you 2 days filled with a lot of insight and constructive collaboration. Thank you very much.
Thank you, Francis. You're indeed perfectly in time. Jörg, do we allow for questions? Francis, if you would be willing to take some.
Okay, go ahead.
Are there any questions from the room?
If there's no questions from the room, there's a few of my colleagues that are in the room that are actually doing joint clinical assessments.
Can you share any kind of early procedural experience on, because you are running some of the assessments or you are involved, or your colleagues?
I'm not, but my colleagues are, and you know that, well, the way this works is following quite strict rules that are set out in a little bit everywhere and also in the framework contract. So what I see is that, well, we have set up this Brussels Center for Collaboration in Health, BCCH. You will hear more of it in the next few days. And actually, they support RIZIV INAMI as the lead of the framework consortium in organizing, for instance, weekly meetings, in the beginning daily meetings between the different clinical acts. This is new business for RIZIV INAMI, but actually and I see it with the colleagues that have a lot of experience in IQWiG and Autorité de Santé. This is new business for Autorité de Santé and for IQWiG also. We learn, but we learn very, very fast. I'm really happy that we have the support of a dedicated team. We have invested in that very well-organized, dedicated team to organize all that collaboration and direct collaboration between the HTA experts, sub-experts, doing all the administrative work, all the legislative work. It's a complicated business. We are a national institute. We're a federal institute. Some of the other HTA agencies are also federal institutes, but we also have private hospitals and academic centers. So the legal entities are completely, you have to imagine how complicated the management of all these different, the contracting of all these different legal entities is. So I'm really happy that we found the right people to do that. Otherwise, it's on content. Please do not, I'm not going to go deep into in the content of the HTAs that are going on for the day, for the time being. It's probably better to ask the experts who are in the room, who are actively involved in these HTAs, how it's going. But I have the impression that it's going quite well.
Francis, can I ask you something about what you mentioned in your talk? You mentioned the terminology, payers, buyers. You mentioned the importance of collaboration. How easy is, given the fragmentation across member states into, in terms of how appraisals, pricing, reimbursement are organized, how easy or difficult is collaboration between the payers slash buyers from your perspective? Because it's not a very homogeneous group.
The answer is going to be double. If you look at countries that are a little bit similar in like purchasing power, but also in vision for the future, and I'm talking about the Benelux group, but I'm also talking about the Nordic collaboration group, even the Baltic states working together. If you look like that, then actually collaboration is not that difficult. Well, administratively it's a hell, but it's not that difficult. You quite quickly find a common ground. Having said that, legislations, procedures, processes differ a lot, and the stakeholders are completely different in different countries. So actually executing then the actual decision-making process, that's a lot more complicated. But finding a common, what we try to do is every time the same thing, and try to find some sort of common vision on what is the value of what we are presented with for the time being. How would we translate that in valorize that in some sort of a proposal for a price and for a positioning of that drug? And could we find like a common, not a price, but some common upper thresholds for what would be the price range for that, and actually that's not that complicated. Translating that in the national legal process is something else, but it happens too. It's not that complicated.
Thank you. I see a question over there. Ruben, please.
Thank you very much for the introduction. One question, how do you see at the Belgium level the role of the state for reimbursement of software as medical device, artificial intelligence as a device that is arriving more and more in Europe? And software, reimbursement of software as medical device.
As what?
Sorry. Medical device.
Oh, software.
Yeah, artificial intelligence solutions that we are speaking more and more in the field of medicine, and in the United States we have some examples. How do you see it in Belgium? What is the role? Yeah.
Well, again, double answer. And a little bit my expertise is in pharmaceuticals, a lot more than in medical devices, or hardly any in medical devices. And this is obviously some form of medical devices. On European level, so really European, I don't know, because this is completely new. This is new, and software has the annoying habit of getting better very quickly and changing very quickly. And most of the HTA process and then the decision-making process take at least a few months before you get there. By the time that you make a decision on the reimbursement of a medical device, most medical devices, and certainly on software, you're going to be outdated. You're going to be deciding on reimbursing something. So probably new models will have to be, or financing models, access models will have to be organized or invented. But that is something where our overseas friends do not completely agree with us, or with, well, I was going to say with me, but it is with us. I think that first looking what the added value might be before you make a decision on pricing or on reimbursement or investing in something, and I mean HTA, is always a good idea. So also for software. It's not going to be health technology assessment, but and probably the technique is going to be a little bit different, but still.
Thank you. Antonella, please. Final question.
So I am Antonella Cardone, Cancer Patients Europe, and we are co-hosting this event with EAA, the European Access Academy, and DHA. So as the theme of today is approaching, is about what we can do while approaching the UHTA, the revision of the UHTA regulation. So how do you see so far how things are going in Belgium towards the objectives of the UHTA regulation, which are accelerating access, reducing duplication? You already mentioned that you have a dedicated and good team. Did you hire anybody in addition to the team that you had before, for instance?
We are confronted in Belgium at RIZIV INAMI with the same or very similar hurdles as many agencies everywhere in Europe. That means no extra personnel, but we found a way around. So have a talk to the people with BCH, they can explain you a little bit more. And it's RIZIV INAMI actually that invested in that, in some sort of pre-financing system for BCH to give agencies the opportunity to hire extra people. We did that too, but not directly, indirectly through BCCH. So yes, we have a dedicated team for that. They are in the room actually, these people. And we would like to invest. The aim is, and that's a bit of a discussion, the aim is that on a longer term, and it's not going to be 4 years, it's going to be 8 or 10 years, This is going to be a win situation for the HTA agencies because normally it's going to save time for, or we will be able to liberate. We won't have to do all the HTAs ourselves. We will be able to liberate our own human resources to do international, so joint clinical assessments. We gain, but that gain is not going to be the idea or the vision of the Commission. Was probably a little bit optimistic in thinking that would be doable within 4 years. This is going to take a bit more time, or a lot more time, probably. So yes, we have extra people, but we couldn't hire them ourselves directly. And we created the possibility for all other agencies to do that too. And that is RIZIV that is paying for that for the time being. Okay.
Thank you very much, Francis, for your talk and for welcoming us in your bunker. We're very happy to be here. Thank you.
If you hear like a strange rumble, that's a subway going under this.
Thanks for the warning. Thank you.